Hello, welcome to Conversations with the Commissioner. My name is Maggie Hart Stebbins, Bernalillo County Commissioner representing District 3, and we're here today to talk about the Bernalillo County Behavioral Health Initiative. So back in 2014, the Bernalillo County Commission asked voters if they would support a new tax dedicated to expansion of behavioral health services. So we've been collecting the tax for about 2 years now, and people are asking, what is happening with those dollars? How are those new behavioral health tax dollars being used? So I'm really pleased that we're being joined by Katrina Hotrum, who is Bernalillo County's Director of Behavioral Health Services, and Dr. Andy Shee from University Hospital, and he's the Director of the Institute for Resilience, Health, and Justice. So Katrina, let's start with you. Tell us, what are we doing with the new behavioral health tax?
Thank you, Commissioner Stebbins, and thank you for having us on today. It's really important for the community to understand what we've been doing and the journey that we've been on in order to make some sound investments with the behavioral health tax. One of the first things that we have done is actually put a system in place that leveraged dollars that were currently existing and tap into systems that were currently out there. One of those things was the New Mexico Crisis and Access Line. One of the big requests from the community, as well as service after service that we would have reports on, stated that we needed to have one central crisis line for individuals who were in crisis or experiencing or nearing crisis to call. We were able to leverage that service through the Department of Human Services at HSD through the state. We've done other things like made connections with community providers and really listened to them about what is needed in the community, and then formulated a temporary governance structure so that we can get community input in order to have that spend. One of the reasons why it's kind of taken us a while to really figure out where the investments are. So to date, we've actually spent some dollars on the behavioral health tax, including reduction of adverse childhood experiences. As you know, last year, the Commission really focused on what we wanted to do with children in terms of prevention and intervention. And we were asking, in terms of the Behavioral Health Initiative, to take a look at maybe $1 million pilot investment on how we can improve outcomes to reduce adverse childhood experiences in Bernalillo County. Well, as you know, because you were one that really pushed on this issue, is that $1 million wasn't enough. $1 million was a start, but we really, if we were going to make a difference, we needed to make a big difference and put at least $3 million a year in investing in our children and reducing adverse childhood experiences. Not only the child who is at risk today, but supporting families so that that child and that family can experience and maintain resiliency and actually improve the outcomes in the future for all children and all families in the future. So that is one of the big investments, and that was our first major initial spend. Now, the exciting thing about that, and the scary thing, of course, is that we were working with the Harvard Institute for Better Government, and we had fellows who actually taught us how to do things like problem-based procurement. And that has been an exciting thing for Bernalillo County, but also a challenge, because it totally makes us rethink about how we're issuing contracts and how we're engaging with providers and how we look at outcomes in the future. And I know Dr. Shee is one of our fantastic providers here, and I know that he's going to talk a little bit more about this. But I think even through the process of problem-based procurement, what we did was go out and say, here's what we know the problem to be. We know that kids are at high risk in Bernalillo County for adverse childhood experiences, more than even the national average. We know that we've got some programs that are successful out there, but we know that primarily dealing with the children because that's reimbursable. What else can we be doing that supports the family or natural supports that actually makes us have healthier outcomes in the future? And so out of that $3 million, we selected 8 providers, and they came to the table and said, here's how we're going to change the outcomes in Bernalillo County for our children and for our youth from 0 to 18 instead of 0 to 5, which was what we were initially recommending, and this is how we're going to serve the community, and this is what you're going to expect to see. And so that, I think, has been a really exciting process. I think you can probably talk a little bit more about the provider experience on that. But I think that's led us to some excitement with providers and in the community that we're not rigid about one way of doing things, but we're looking at all sorts of creative, evidence-based ways of effective practice so that families have a choice and families have options in terms of getting the kind of help and the care that they need.
I think it's so important what you said about prevention of adverse child experiences, because the original data and literature didn't really talk about prevention. And it was looking at older people who had a lot of adverse child experiences in their lifetime. So to have this opportunity to work with Katrina Hotrum and Behavioral Health in the county on prevention is taking the science to a whole new level. So we're really pleased to be a provider to try to deliver these services.
So you, through the request for proposals process, I know that you were chosen as one of the providers that we'll move forward with. But I also know you have a long history of really caring for children in this community who might be in crisis. You know, children who are struggling with different issues. So can you talk a little bit about your history and how this contract with the county fits into that continuum?
Happy to explain that. I think the first thing that is really interesting is we did a research study looking at kids who are incarcerated in the state juvenile facility, the Youth Diagnostic and Detention Center. And what we found for that group of youth, who come from all over the state, is that they had, by the time they were incarcerated, accumulated a really large number of adverse childhood experiences. Their average was 5.3 experiences, and almost 30% of them had 7 or more adverse experiences out of a total of 9 or 10. So these are kids who'd had a number of different things go on in their life that didn't go well. One of the hard things to understand is that most adverse experiences are occurring in kids before 3 years of age. And they're not even able at that point to verbalize what's going on for them.
Yeah.
So based on this group of kids who are incarcerated, we began to think about what would happen when they're released, and how could we do things to interrupt further adverse experiences in their lives, and potentially, if they were parents or going to be parents, do things so that at that time their risk of having adverse events to the next generation would be decreased. So when this opportunity came out through the gross receipts tax to look at prevention of adverse experiences, we thought a lot about kids who are in the Bernalillo County Detention Center. And the good news is that they're younger. We don't think they have quite the accumulation of adverse experiences that kids in the YDDC have, but we know that they have significant needs that upon discharge need to be captured in a way that increases their chances of doing well. So the administration at the Youth Service Center has been fantastic about being willing to collaborate. The medical personnel there, the family medicine doctors from UNM, the psychiatrists from UNM who go there to support the kids at detention, have been really great about thinking about what's the warm handoff. How do we support the needs of kids in that setting, and then as they are released, continue the care that's been started there so that they have a better chance of good health outcomes.
Can we take a quick step back? Adverse childhood experiences, ACEs, what are they?
Sure. So the research about them indicated that if kids growing up before age 18 had experienced of physical abuse, psychological neglect or abuse, or experienced sexual abuse, that those were potent predictors of poor health outcomes for the individual. And then in addition, if they lived in a home that was affected by parental substance use disorder or alcoholism, or lived with a parent or caregiver who had severe mental illness or depression or suicide attempts, or lived in a home where there's violence directly against the mother or stepmother, or had a family member or caregiver who was incarcerated, or lived in a home where a parent or a caregiver just walked out of their lives, that those situations when they were accumulated, predicted for much worse health outcomes and higher health risk behaviors than for individuals who had only one adverse experience in their life or had no adverse experience in their lives. So the original data looked at adults and took a backwards look at their life. How many adverse experiences had they accumulated by age 18? And now in their middle age, what was their health life like? And they found an association between poorer health outcomes, greater risk for heart disease, diabetes, overweight, obesity, psychiatric issues, drug abuse, alcoholism, chronic lung disease, that increased as the number of adverse experiences in their lives increased. It was almost like a dose-response kind of model. The more adverse experiences, types of adverse experiences a person had in their life, the greater their risk for poor health. And in fact, of the 7 leading causes of disease and death in the United States, 6 of them are tied to behaviors that could be driven by the experience of having those adverse experiences.
Wow. So tell me about the Adobe program. So your response.
Great. So what we said we wanted to do in the Adobe project was to look at kids who are coming out of detention and do things to reduce their risk of being reincarcerated. And so what we said in working with the administration at the detention center was that we would try to focus on kids who had 2 or more admissions to the detention center in the previous year. So we wanted to take the group of kids who are at the potential highest risk of having further legal entanglement and progressing to the adult correction system. And in doing that, we would organize a medical home model to provide comprehensive medical and psychiatric services within the context of a medical visit, as well as connecting them to components of the UNM Law Clinic to address civil legal needs. So we're thinking from the Institute perspective, how do we reduce health disparities and how do we reduce justice disparities? And so one of the ways of doing that is putting those services together in one place. But we also understand that when kids have adverse experiences, those adverse experiences originate from their environment. And in order to try to address those, we are in the process now of interviewing for navigator positions, individuals who we will have meet the kids in detention and then follow those kids to their homes and meet their families and try to understand what it is in the family systems that need to happen so that that kid has a good health outcome and less risk of encountering the justice system. And then we'll hire another group of people called educational liaisons who will interface with the schools the kids go to with the idea of understanding from the school personnel what it is that needs to happen so this kid's able to go to school. If they have medical issues, what needs to happen so their chronic medical conditions don't interfere with their attendance, and how do we help them make academic progress. So 2 big goals: try to reduce repeat events with the detention center, and then secondary goals to increase their health parameters and their mental health parameters to address things like substance use disorder medically, and then to increase the likelihood they attend school and get a degree.
What was the likelihood, I don't know if this was part of your research, that children who are incarcerated had substance use disorders already? Or mental health issues?
Well, in the population at YDDC, 96% of them had a substance use disorder when they started. And 100% of them had an Axis I psychiatric diagnosis. They had a serious psychiatric diagnosis. So that would mean at discharge, these are things that they're going to have potentially affecting their life from the time they leave and through adulthood. And there needs to be a systems model that says, okay, we're going to take on the co-management of these care needs so that when they turn 22 or they turn 26 and go off their parents' insurance, they suddenly aren't kind of adrift in terms of how to address these complex issues. About 1/3 of the kids in detention, in the YDDC had special education needs. And so we think that the kids in detention will probably have a set of complex academic needs that need to be organized and addressed. And sometimes that will mean that they need further diagnosis to understand what their educational needs are. Sometimes it may mean that they need better medication management. And sometimes it may mean that they need adults who can be involved with them. The one thing else I guess that really has struck me is that when we talk about adverse experiences, and there are terrible things that happen in people's lives, but we're encountering people who survived them and who have had these things happen to them and are still struggling, still trying to make headway. And I think the more I try to understand how we can best help them is to acknowledge the internal strength, the drive, motivation that allows people to keep going, and doesn't think of having had adverse experiences like a lifelong disability, but rather a set of conditions that need to be examined, need to be diagnosed, need to have good treatment and compassionate continuing care so that people can move through them and then get on with their lives to optimize their life function.
And I just want to say thank you for the research that you've done and the initiatives you've undertaken. I think for many of us in the community, these problems aren't evident. And I think most people don't really think about what brings children into the criminal justice system. And some of the work you've done, I think, has really begun to open people's eyes about why they end up there and how to intervene before it becomes sort of a lifelong habit or a lifelong condition in and out of incarceration.
Right.
So thank you for that.
We're grateful for the opportunity, and the other part of it is that if we identify in the family system needs that could exacerbate the risk of adverse experiences, we will offer the primary medical home to the extended family. So we'll see the parents if there's a substance use disorder that's not being addressed, if they don't have access to mental health care. We're going to try to at least initially see them, understand the issues, and initiate care so that hopefully we can stabilize the whole family system simultaneously to create the best health outcome for the entire family system.
Children, brothers, sisters, all
siblings
can access your services.
Yeah. We had one family come in and the guardian of the kids said, I have 2 other kids in the home and they don't have primary care. We said, sure. We'll have appointments. Let's see them. Let's see what we need to do. And you know, as we meet family systems, we understand that the other kids who have not had contact with the criminal justice system, we might have a better chance of doing really good interventions or prevention so that they resolve things before they act out in a way that gets them arrested.
Katrina, can you give other examples of some of the programs that have also been funded under the...
Certainly. I just wanted to comment just one more thing on the ACE sort of initiative and experience. I think that what we've learned through this process is our providers were able to assist us in actually getting to what we think some of the root of the problems are with prevention and intervention initiatives. And even though it might take a while to really see what these long-term outcomes are, you have confidence and understanding that we know the target population, we know how to identify those individuals and those families at risk, and providing the wraparound service such as Dr. Shi is doing is critical to the stabilization and resiliency of families, and then that child's success in the future when they have families themselves is really hopefully stopping the problem from continuing. And I'm amazed at this project and just so excited about seeing what these outcomes are. So I think that's just thank you. In terms of other things that we're doing, just along the lines of youth, we have invested $650,000 in youth transitional services. And the hope there is to link some of these services in with reduction of adverse childhood experiences if individuals or kids need a place to go, really working on them and finding a place for them to be and stabilizing their lives so that their outcomes improve. It's also linking into and partnering with the University of New Mexico Hospital, who is now providing adolescent detox for this population. These kids can't go home. It's linking them into these services and continuing on a track where they can maintain and be successful. So we're very proud of that. We've launched phase 2 of Community Connections. Phase 1 was really focusing on individuals that were incarcerated coming back into the community and needed supports and supportive housing. Phase 2 of that is really looking at the frequent utilizers that are living in the community and how can we, that are homeless or precariously housed, and how can we stabilize that population so we can do a diversion from the emergency room or from those high-level services that they're accessing, as well as hopefully divert them from the criminal justice system as a whole. So we've launched that. We're starting to admit individuals into that program as well. We also know that through the efforts with Community Connections, that there is a higher need population than what we can serve in scattered site. And so we have been working with the City of Albuquerque at looking at launching a single site supported housing model with the intent of housing individuals who have increased needs that maybe can't live by themselves in the community, can have their own apartment, but services right there on the site so that they can have medication management, access to case management, they can engage with their peers, have assistance with transportation if needed, and be able to live in their most independent setting and have some structure around them. So we're building out that component. And other things that we're doing, like mobile crisis teams, which I think is very important to stabilizing this community. And that's working with law enforcement. Actually, hopefully in just a couple of weeks, we will be announcing our provider for mobile crisis team, and that has been a shared effort between the city and the county to identify one provider that is going to go across city and county lines with the sheriff's department and police department so that we have continuity of response services for people experiencing a behavioral health crisis who dial 911 and get into the behavioral health or into the 911 system. So we want these better outcomes. We want positive engagement with law enforcement and better outcomes for the client so that they're getting the services that they need, not always at the jail, but also in the community as well. So those are some of the big initiatives that we're working on. In addition to that, because a certain county commissioner has really pushed us at looking at the efforts that we need to do in the jail, Commissioner Stebbins has really pushed us at looking at how do we provide some stabilization services in the jail, and then how do we connect these folks into the community being stabilized. And one of the ways that we can do that is not just through services that actually that they can access in the jail, but how do they link then into the community? So efforts that she has pushed forward, such as medication for chronic illness and chronic disease and mental health, and actually having those medications upon release, it's only going to help improve the outcome. But we know that that could only be for a short period of time, which is why we need a resource reentry center so that individuals who are at risk of recidivism, at risk for these high mental health issues, at risk for going back into the criminal justice system, have a place to go, have a place to be seen and connected directly with services so that we can improve their health outcomes overall in the community. I think one of the things that the Behavioral Health Initiative has taught us is that we shouldn't be isolated. We should focus on behavioral health, but that is one determinant that needs to be looked at in terms of really doing what we've got to do, which is improving outcomes and health outcomes in our community, which I think is what we're committed to do.
I just like that idea so much that these providers are basically kind of linking hands and wrapping our arms around this group of people who are at high risk for poor outcomes and saying, let's embrace you and figure out how to help you the best. And I think ultimately what that ends up doing is it reduces adverse experiences, but also begins to help lift people up so that they are able to do things for themselves, be able to make decisions, and by doing that, it lifts us all up. And it's an incredibly inspiring body of work.
It certainly is.
So I want to thank you for your work, Katrina. Thank you for your amazing work you've been doing putting this together.
Thank you.
I think I have often heard of MDC, our local jail, being described as the largest behavioral health hospital in the state of New Mexico. We do have a high number of inmates who suffer from behavioral health disorders, substance use disorders, and often end up in jail either as a result of something they've done or because they can't find treatment anywhere else, and sometimes law enforcement doesn't know where to bring them. And so the more we can provide appropriate services through this new gross receipts tax, the better we're all going to be, both the person who's suffering and taxpayer, because providing care at MDC is probably the most expensive, most inappropriate place to deliver those services. So we'll continue working with the community, providers, families, people, consumers, to continue building out this process. So I want to thank you both for joining us today.
Thank you.
And for your great work.
Thanks for your leadership on
Yes.
this. It would be impossible without it.
Yes, thank you.
And thank you to everyone who's joined us today for conversations with the Commissioner. We'll see you soon.